There is one bone in your body that does not touch any other bone. No joint, no articulation, no point of bony contact with the rest of your skeleton. It sits suspended in the soft tissue of your throat, held in position by muscles and ligaments pulling on it from 7 different directions at once: upward, downward, forward, backward, left, right, and diagonally outward. And the location where those 7 forces find their balance turns out to be one of the most important structural facts about the lower half of your face. It is called the hyoid. You can find it if you know where to look. Run your finger along the front of your throat, just below your chin and above the hard ridge of your larynx. There is a soft space there, and somewhere inside that space, roughly level with the 3rd vertebra of your neck, the hyoid sits. A small, U-shaped bone, roughly the size of a wishbone, the only bone in your body connected to no other bone at all, the only one that floats. Most people discover it by accident, if they discover it at all. It does not ache in a way that prompts a doctor's visit. It does not show up in the mirror. It exists in the deep architecture of your throat, doing something quietly foundational. And the fact that it matters to the appearance of the face is almost never part of any conversation about aging that women are invited to have. I want to have it with you now. If something has changed in the lower half of your face, the territory below the jaw, above the neck, that zone where the chin meets the throat, and you have tried the approaches that are supposed to address it and found them incomplete, there is a possibility worth examining carefully. The change may not be originating in your skin. It may not be originating in the fat compartments beneath it. It may be originating 2 centimeters deeper than any filler has ever reached, in the position of the bone that floats. Let me tell you what I mean by that, and let me start where the anatomy actually starts, because this is a story that only makes sense from the inside out. There is something almost philosophically interesting about the hyoid. Every other bone in the human body is embedded in the skeleton through contact, joint surfaces, cartilage, bone meeting bone in some form of physical relationship. 205 bones connect to at least one neighbor. One does not. The hyoid exists as a kind of free agent within the architecture of the body, stabilized entirely by the muscles and ligaments that attach to it, held in equilibrium between forces rather than locked in place by structure. You could argue it is the most honest bone in the body. It goes exactly where the forces pulling on it actually take it. There is no structural resistance to where it ends up. That absence of resistance is what makes it significant. The muscles that hold the hyoid in space organize into 2 clear groups. Above the bone, connecting it upward to the jaw, the chin, the tongue, and the base of the skull, sit the suprahyoid muscles. These are the structures that pull the hyoid toward the skull. Below the bone, connecting it downward to the sternum, the shoulder blade, and the cartilage of the larynx, sit the infrahyoid muscles. These are the structures that pull the hyoid toward the chest. The hyoid's position in your throat at any given moment is the equilibrium between these 2 opposing poles. Neither group is meant to dominate. They are designed to balance. The design equilibrium is not an accident. The geometry of the suprahyoid and infrahyoid muscles was shaped over a very long period of evolution to place the hyoid at a specific height in the throat, roughly at the 3rd cervical level, in a position that allows it to serve its many functions: to anchor the tongue, to assist the swallow, to maintain the patency of the airway, and, significantly, to provide structural support to the floor of the mouth in the submandibular region above it. When that design equilibrium holds, something specific happens at the surface. 2 of the suprahyoid muscles are not simply pulling on the hyoid from above, they are also structural components of the face itself. The mylohyoid spans the interior of your lower jaw like a hammock, running from the inner surface of one side of the mandible across to the other, with the hyoid as its anchor point at the base of the midline. It creates the muscular floor of your mouth, and through that, the structural ceiling of the submandibular space, the territory you see between your chin and your throat. When the hyoid sits where it was designed to sit, the mylohyoid has the tension it was built for. The submandibular space is supported from below, and the structures resting on top of it, the skin, the subcutaneous fat, the platysma muscle running from the collarbone up the neck, are sitting on a scaffolding that is doing its work. The digastric muscle runs from a small notch just behind the chin, outward and slightly backward, passing through a connective tissue sling that loops around the hyoid before continuing toward the mastoid process behind the ear. This muscle, when positioned correctly, creates a precise angular line from the chin toward the jaw angle. That line is part of what people mean when they describe a sharp jaw. Not genetics alone, muscular architecture, under tension, creating definition from the inside. When the hyoid descends below its design position, both of these structures change. The mylohyoid's hammock sags. The angle of the digastric shifts from something close to horizontal to something more diagonal, pulling more downward. The submandibular space, which had muscular support beneath it, gradually loses it. The skin and soft tissue above these muscles are no longer sitting on a scaffolding that is maintaining its structural role. They are sitting on something that is quietly, incrementally given way. That is the mechanism, and it is rarely discussed in the conversation about the aging face. Not because it is controversial, but because the bones and muscles of the deep throat simply are not what most practitioners examine when someone sits down across from them looking for explanations. Now, why does the hyoid descend in the first place? The position of this bone is directly linked to the position of your head. Not your face, your skull. The infrahyoid muscles, the ones anchoring the hyoid from below, have their lower ends attached to the sternum and the clavicle. Both are fixed in the thorax. They do not move. The hyoid does. So when your skull moves forward relative to your shoulders, when the head adopts a position where the ears sit in front of the shoulders rather than directly above them, the distance between those fixed lower anchor points and the hyoid increases. The infrahyoid muscles, stretched across that increased distance, exert a downward pull that the suprahyoid group must counterbalance. When the cumulative load tips the balance, the hyoid descends toward the chest. Forward head posture is how this happens most often. And it has become so ordinary in contemporary life that many people no longer experience it as a postural deviation. It simply feels like how they hold their head. The chin moves slightly forward. The skull sits a centimeter or two in front of the shoulders. The deep muscles of the back of the neck work harder than they were designed to in order to support a head that is no longer balanced directly above the spine. This is not unusual. Cephalometric studies, the head measurement research used in orthodontics and oral surgery, have documented forward head posture in the majority of adults examined, with the degree increasing across both age and accumulated sedentary screen time. Every hour your skull occupies that forward position, your infrahyoid muscles are under altered tension. Every night you sleep with your chin propped forward on stacked pillows, a position that pushes the lower jaw forward and changes the hyoid's relationship with the cervical spine, you spend multiple hours in a posture that reinforces a lowered resting equilibrium. The screen angled down on the desk, requiring the chin to drop and the head to tilt. The seat reclined in the car, tipping the head forward. The book resting in the lap rather than held at eye level. These are not individual acts of carelessness. They are simply ordinary life, experienced by almost everyone. But the hyoid is recording all of them. In the face is the ledger. Something else is worth naming here, because it tends to begin earlier than people realize. The surface changes that become visible in the lower face during the late 40s and 50s often reflect structural shifts that began accumulating years before, in some cases a decade or more before the skin showed anything. The bone was drifting before the mirror showed it. The scaffolding was changing before the change became visible. This is not a reason for alarm. It is a reason to understand that you are not looking at a sudden event. You are looking at the accumulated record of a long, slow positional shift. And long, slow positional shifts have long, slow positional solutions. The good news, and it is genuinely good news, is that the hyoid's resting equilibrium is not fixed. It was never fixed. It reached its current position through a process of gradual adjustment, and that same process runs in the other direction when the inputs change. The bone moves. It was always capable of moving. Nobody told you that the way it had moved mattered to your face. Before we go further into the mechanism, and there is considerably more to understand before the practical work will make full sense, I want to tell you about something I developed specifically for this system. Everything I have explained so far, the hyoid's floating position, the suprahyoid and infrahyoid balance, the relationship between daily head position and the architecture of the lower face, is the foundational anatomy underlying 12 fascial release exercises I have sequenced into a 30-day protocol. The complete system is in a resource called the Connected Face Protocol. 12 releases, arranged over 30 days in a specific sequence so that each exercise builds on the preparation of the previous one, with labeled anatomical diagrams showing exactly where to place your hands for each exercise, and a daily tracking sheet so you can notice what changes over time and document your own observations. You will find it in the description and the pinned comment. Now, back to the mechanism, because the most important part is still ahead. The 2-force system I described is not a static arrangement. It is dynamic, continuously responsive to every head position you adopt, every swallow you make, every vowel you produce in speech. The hyoid micro-adjusts through all of it. What we are describing when we talk about hyoid descent is not a single dramatic failure, but the resting position the system has settled into as its default, the equilibrium the bone returns to when nothing specific is demanding movement, the location that reflects the average of years of input. Cephalometric research comparing hyoid position to cervical alignment has documented something important. Hyoid height changes as head position changes, and it changes systematically. In populations studied for cervical rehabilitation, people working through chronic neck pain, through postural rehabilitation programs, changes in cervical alignment produced measurable changes in hyoid position. The bone moved when the head moved. This is not a theoretical relationship. It has been measured repeatedly in clinical populations across different institutions. The bone is responsive. What this tells you is that the position the hyoid has settled into is not a verdict. It is a current state. And current states, reached through gradual processes, can shift through gradual processes in the opposite direction. If you understand what you are actually working with, and if you work with it in the right direction. The question of exactly what that direction is, what specific work moves the hyoid, and through what sequence, is something we are going to get to precisely. But first, I want to spend some time with what the descent actually produces at the surface, because this is where the conversation becomes most useful for understanding why certain approaches work and others do not. There is a composite of experience I want to describe, not a single person, but a pattern that recurs across many people working through this, woven into one set of observations, because that is more honest than presenting one individual as representative of all. She was attentive to her face, not vain, precise. The kind of person who investigates rather than simply reacts, who reads the research when something is recommended to her and asks the next question. She noticed the changes in her lower face in her early 50s with the clarity of someone who has been paying careful attention for a long time. The change was in the submandibular region, the territory between the chin and the angle of the jaw, and it had a quality she described as persistent, as if that area had a preference for a certain kind of looseness that nothing she tried was fully resolving at its root. The approaches she used were not misguided. Volume restoration helped, temporarily. What she did find was that the results were correct in kind, but incomplete in scope. The midface looked refreshed, but the jawline's definition kept returning to something softer than she expected. The looseness was located specifically. It did not spread across the face the way a skin laxity problem would. It concentrated in one zone, and it kept coming back there. What she could not yet see was that the zone she kept returning to was tracing, almost precisely, the muscular territory of the suprahyoid group, the mylohyoid, the digastric, the floor of the mouth, and the scaffolding that had once held the submandibular space taut. She was experiencing the surface expression of a structural shift she did not yet have a language for. When she encountered the hyoid conversation, not as a revelation, but as a piece of anatomy she then spent considerable time reading about, she described the experience later as recognition rather than discovery. Not, "I never knew this," but "this explains what I kept noticing." The geometry of her own observation fit the anatomy. The persistent looseness in the specific location, the way it did not fully resolve at the surface, the way it followed a line. She began working with her head position. Not dramatically, she made the screen adjustments we will discuss. She learned the tongue to palate engagement. She spent time in the position reset I am going to show you. She did not transform. She noticed over the following months that something had shifted, and the shift arrived the way the change had come in the first place. Slowly, in the same persistent location, but in the other direction. I am going to tell you what the descent actually does at the level of tissue before we discuss what can be done about it, because understanding the cascade is what makes the protocol make sense rather than feel arbitrary. When the hyoid descends, the effects propagate upward through the suprahyoid muscles in a cascade. Start with the mylohyoid. This muscle spans the interior of the mandible like a hammock, its fibers running nearly horizontally from side to side at their medial attachments, converging toward the hyoid at the midline below. When the hyoid is at its designed height, the mylohyoid has a specific resting length and tension. It is neither taut nor slack, but loaded in the way it was designed to support the structures above it. The floor of the mouth is slightly elevated. The soft tissue of the submandibular region has something pushing up against it from below. When the hyoid descends, even by a relatively small distance, the mylohyoid's effective length must increase to bridge the new distance. A muscle under insufficient load does not maintain its structural position, it accommodates. The hammock deepens. The submandibular floor drops. The structures above it, which had been resting on that tension, find less support beneath them. They respond to gravity rather than to the muscle that was, in better circumstances, resisting gravity on their behalf. The digastric tells a related story. Its anterior belly runs from the mental spine of the mandible, just behind the chin, outward and slightly backward through that connective tissue sling looped around the hyoid. When the hyoid sits at its design height, the angle of this muscle creates a relatively horizontal line from chin to sling. That horizontal angle is part of what creates the visible distinction between chin and neck, the sharpness of the angle, the clarity of the line. As the hyoid descends and protrudes, the sling lowers with it. The digastric's angle changes from something close to horizontal towards something more diagonally downward. The precise chin to neck distinction softens, the line blurs. Above both of these muscles sits the platysma, the broad flat muscle that covers most of the anterior neck and sweeps upward over the jawline. The platysma does not attach to the hyoid directly, but it overlies the structures that do, and its surface appearance reflects their position. When the submandibular scaffolding has good tension, the platysma rests against it, and its surface appearance is correspondingly taut. When the scaffolding has descended, the platysma drapes over whatever is beneath it, and the result is visible at the surface as the quality most people call a soft jaw, or, if the vertical bands have developed, a changed neck appearance. There is one more consequence worth naming, because it speaks to the CW question about why volume and skin approaches alone do not fully solve this. When practitioners examine the lower face and observe volume loss, and the fat compartments of the face do descend with age, this is real and documented, they are observing something true. But if the scaffolding beneath the soft tissue has also descended, restoring volume above that descended scaffolding is like adding weight to a hammock that is already deepened. The volume sits in a space that is now lower than its design position. The results are correct in kind. They address what they address, but the structural floor below has not moved. This is the question that CW cannot answer. Why, when volume is restored beautifully in the midface, does the submandibular region keep returning to softness that traces almost exactly the territory of the suprahyoid group? Why does this specific pattern, this specific location, this specific shape persist across interventions that genuinely address what they claim to address? The pattern is telling you something about its origin, and the origin is deeper than the treatment has been reaching. Volume loss is real, skin laxity is real, and below both of them, in a position no surface intervention can reach, a bone has drifted downward and taken its muscular attachments with it. Let me offer you a frame for what this looks like from the outside, and I am going to borrow it from somewhere seemingly unrelated because the mechanics map precisely enough that the comparison is genuinely clarifying rather than decorative. Consider the orbital mechanics of a small satellite caught between two gravitational bodies. Not a metaphor in the loose sense, a specific physical system with properties worth understanding. The satellite sits in a gravitational equilibrium between two larger bodies, pulling on it simultaneously from opposite directions. The gravitational field above it pulls the satellite upward. The gravitational field below it pulls the satellite downward. The satellite's orbit, its position in space, is the stable equilibrium between these two fields. As long as both fields maintain their relative strength, the orbit holds. The satellite stays in its design location. Now change one field. Allow the lower gravitational body to grow stronger. Perhaps it gains mass. Perhaps the satellite moves slightly closer to it. The satellite's orbit shifts downward. Not dramatically. In the early stages, the shift is small. But as the new equilibrium establishes itself, several consequences follow. The satellite is now closer to the lower body than it was designed to be. The angle at which it relates to the upper body has changed. The gravitational relationship between the satellite and every other object in that system, the secondary moons, the debris and surrounding orbits, shifts accordingly. What moved was the satellite's equilibrium, and everything attached to that equilibrium moved with it. The hyoid is that satellite. The suprahyoid group is the upper gravitational field, pulling the bone upward toward the jaw and skull. The infrahyoid group is the lower gravitational field, pulling it downward toward the sternum and shoulder. The hyoid's resting position is its orbit, the position it returns to when nothing specific is demanding movement. When forward head posture strengthens the effective downward pull of the infrahyoid group, when the skull's forward position increases the distance those muscles must span, and therefore the tension they exert, the orbit of the hyoid shifts downward, and everything attached to the hyoid moves with it. The floor of the mouth, the submandibular scaffolding, the precise angles of muscles whose surface expression you can see in the mirror. What makes this framework useful is the same thing that makes orbital mechanics useful. It tells you where to intervene. Restoring the satellite's orbit does not mean strengthening the satellite itself. It means returning the gravitational balance to its designed relationship. Reduce the pull of the lower field, strengthen the pull of the upper field, or, most powerfully, move the whole system back to the configuration from which the designed orbit makes mechanical sense. In the case of the hyoid, that means the head. The head is where the intervention begins. She noticed it first in photographs. Not in the mirror, photographs. There is something about the fixed angle of a photograph, taken by someone else at an ordinary moment, that registers differently than the mirror does. The mirror has movement, has light that shifts, has the face in a slightly different expression each time. A photograph holds one moment still. She noticed, in photographs taken about 3 months after she had begun working with her head position, after she had spent those months adjusting the screen, practicing the tongue to palate engagement, doing the position reset in the mornings, that the light under her jaw was different. The shadow that had been there was slightly less heavy. The line was slightly more defined, not transformed. She was not looking at a different person. She was looking at something she recognized, a quality that had been present before, that she had watched diminish, and that was now tentatively returning. She used the word familiar when she described it. Not better, familiar. As if a quality of her own face that she had known for a long time had come back to a place she recognized. That quality, the light under the jaw, the line, the familiar definition, has an anatomical address. It is the suprahyoid scaffolding holding the submandibular space in its designed position. It is the mylohyoid at the tension it was built for. It is the digastric at an angle that creates a line rather than a slope. All of this is underneath, invisible, doing quiet structural work. When it works correctly, the surface reflects it. When it works correctly, the face has a quality that serums and procedures can approximate but cannot produce, because what they address is the surface expression of a structural arrangement they cannot reach. Now let me offer you one more frame before we get to the protocol, because this one is the one that changed how I think about what is actually being asked of the tissue. Suspension bridges are among the most elegant engineering structures humans have built. They solve a specific problem: how to span a long distance without resting the weight of the roadway on the material below it, through a solution that involves continuous tension rather than compression. The roadway does not push down against supports from below. It is held up from above by cables under tension, which in turn are anchored at both ends and run over vertical towers that give them their height. The system works because both tension elements, the main cables running overhead and the vertical suspenders running from cable to roadway, are in calibrated, simultaneous tension. Neither element can fail without the other being affected. Map this to the hyoid system, and the parallel is striking. The main cables of the suspension bridge, anchored at each end, running up over the towers, are the infrahyoid muscles, anchored at the sternum and clavicle below, running up and over the hyoid at the midpoint. The vertical suspenders, running from the main cable downward to the roadway, are the suprahyoid muscles, running from the hyoid upward to the jaw and skull. The roadway itself, held flat and taut by the tension above it, is the submandibular region, the floor of the mouth, the tissue beneath the chin, the territory whose surface appearance most directly reflects whether the tension system above it is working. When the main cables sag, when the infrahyoids lengthen because the head has moved forward, changing the distance between their fixed anchor points and the hyoid, the angle of the vertical suspenders changes. The suprahyoid muscles, still attached to the same jaw and skull, now pull at a different angle because the point they are anchored to below, the hyoid, has shifted. The tension in the suspenders decreases. The roadway, no longer held with its designed tension, begins to drop. Restoring the roadway is not done by working on the roadway. It is done by returning the cable system to its designed configuration. In the body, that means returning the skull to its designed position above the spine, reducing the forward displacement that tips the infrahyoid tension, and reinforcing the suprahyoid engagement that holds the hyoid where its orbit was designed to be. This is what the following protocol is designed to address. Here's what I want you to practice, specifically, with specific timing and specific body positions. 4 practices, each with a distinct purpose in the system. The first is the position reset. Do this lying flat on a firm surface, not a mattress, but the floor, with a thin folded towel under your head if the back of your skull needs it. No pillow under the neck. You are looking straight up at the ceiling. Take a moment to feel where your skull actually contacts the surface. This is your anatomical starting point, the position from which the cervical spine was designed to operate when unloaded. From this position, very gently draw your chin toward your throat without lifting your head from the floor. This is a small movement, 2 or 3 centimeters, not dramatic. Think of lengthening the back of your neck rather than pressing your chin down. What you are doing is reducing the distance between the sternum and the floor of the mouth, restoring, temporarily, the designed relationship between the fixed lower anchor points of the infrahyoids and the hyoid above them. Hold this gentle chin-in position for 30 seconds, breathing normally through your nose. Release. Repeat 5 times. The entire practice takes approximately 2 minutes. Do it once in the morning, before you begin the activities of the day. What you may notice, toward the end of the 5 repetitions, is a slight sensation of increased space at the base of the throat, a quality of the anterior neck being slightly longer. This is the infrahyoid group momentarily in a less elongated position, and the suprahyoid group beginning to register their designed length. You are not doing anything aggressive. You are simply showing the system what its designed starting position feels like. The second practice is the tongue to palate engagement. Sitting or standing, with your head in a neutral position, ears above shoulders, chin not pressed down, not jutted forward, Press the entire length of your tongue firmly against the roof of your mouth. Not the tip alone, the full surface of the tongue, from its front edge to as far back as you can comfortably reach, pressing up against the hard palate. Hold this contact firmly while breathing through your nose. What this activates is the mylohyoid muscle, the hammock of the submandibular region, along with the other suprahyoid muscles that run from the tongue base to the hyoid. You are engaging the entire upper gravitational field. Hold for 30 seconds. Release. Repeat 3 times. Do this 3 times across the day, morning, midday, and evening. You do not need a dedicated moment for it. 30 seconds of tongue to palate while waiting for anything is sufficient. If you place 2 fingers lightly on the soft space under your chin while doing this, you may feel a slight firmness develop in the submandibular region during the hold. That is the mylohyoid and its neighboring muscles engaging. That is the scaffolding switching on. The third practice is swallowing awareness, and I am asking you to observe something rather than correct it. Spend 1 meal, just one, without any self-consciousness. You are simply noticing, paying attention to what your tongue does as you swallow. An optimal swallowing pattern involves the tongue rising to press against the roof of the mouth as it propels food or liquid backward. This movement creates an upward force vector on the hyoid. The hyoid elevates during a correctly patterned swallow. An alternative swallowing pattern, one where the tongue pushes forward against the back of the teeth rather than rising to the palate, creates a forward force vector on the hyoid rather than an upward one. Over thousands of swallows per day, this difference in vector accumulates. You are not trying to change your swallowing pattern today. You are observing which pattern you have because that observation is the beginning of awareness that can, over time, allow the pattern to change. The fourth practice is not a discrete exercise. It is the most impactful thing you can do, and it operates across every hour of your day. Bring your screen to eye level. All of them. The phone, the monitor, the laptop, the tablet. Every hour you spend looking down at a screen below eye level is an hour of forward head posture, which is an hour of altered infrahyoid tension, which is an hour of the lower gravitational field pulling the hyoid downward. No amount of isolated exercise offsets hours of structural load in the wrong direction. A book on a stand, a laptop elevated on a stack of books, a phone held at face height rather than lap height. These are not vanity adjustments. They are the single most structurally significant daily change available to you. If you do only one thing from this conversation, make it that one. There are people for whom this is entirely new information. The floating bone, the 2-4 system, the relationship between daily head position and the architecture of a lower face. There are others for whom something in the past hour has felt like recognizing what they already half knew. Either way, something has changed in how you see the face now. It is no longer a surface, not entirely. There is a bone beneath it, suspended in the throat, responsive to years of ordinary living, maintaining a position that the face above it reflects. You can see that now. You can see, when you look in the mirror, the submandibular territory with some sense of what lies beneath it. The hammock of the mylohyoid, the angular precision of the digastric, the quiet orbit of the hyoid at the center of 2 competing poles. This kind of seeing changes what is available to you. Not because seeing alone does anything to the tissue, but because you can only work with what you can accurately perceive. And what you can now perceive is a structural system with a structural address. The head, the hyoid, the 2-force balance that daily life has been acting on without your knowledge for years. There is someone you know who has been looking for this conversation. Not this video, not even this channel, the idea itself. The idea that the bone that floats, the only bone in your body connected to nothing but the forces pulling on it, sits at the center of the architecture of the lower face, in that its position reflects the accumulated record of every ordinary hour of every ordinary day. Think of one specific person, someone who has been trying to understand why the lower face changes the way it does, who has looked into the available explanations and found them incomplete, who has the kind of mind that, given this piece of anatomy, will keep thinking about it long after the conversation ends. Not the video, just the idea. You do not need to send a link. You need one sentence. There is a bone in the throat that floats, connected to nothing else, and where it sits is one of the main reasons the lower face looks the way it does. See where that takes the conversation. Some of the most important medical and anatomical knowledge travels that way, person to person, from someone who encountered it to someone who needed to. The bone that floats has been there the entire time, doing its quiet structural work, waiting for the conversation to catch up with it. There is a particular kind of quiet that settles in after an idea like this lands. Not the quiet of boredom, and not the quiet of confusion, the quiet of recalibration. Somewhere in the last hour, a piece of your own anatomy stopped being background information and became foreground. That shift rarely announces itself loudly. It shows up later, in small moments. You will catch yourself, days from now, tilting your head forward to read something on a screen, and for half a second, you will feel the throat, the space beneath the jaw, the quiet suspension of that floating bone. And you will understand, in a way you did not before, what that posture is asking of the tissue that surrounds it. This is what real anatomical literacy does. It does not fix anything by itself. No amount of understanding the 2-4 system changes the position of your hyoid tonight, but it changes your relationship to your own posture, your own habits, your own accumulated hours, because you can no longer look at the lower face, yours or anyone else's, as an isolated surface problem. You now know there is an architecture beneath it, a suspended bone held only by muscle, answering only to the forces acting on it. And you know that one of the most powerful forces acting on it, every single day, is the angle of the head relative to the spine, sustained for hours, across years, without a single moment of active correction. Let's return to the digastric for a moment, because there is more here worth sitting with. The digastric is unusual even among unusual muscles. Most muscles in the body run from one bone to another in a single continuous line of pull. The digastric does something stranger. It has two bellies, an anterior belly and a posterior belly, joined not directly to each other, but through an intermediate tendon that loops through a small fibrous sling attached to the hyoid itself. This means the digastric does not simply pull the hyoid in one direction. It uses the hyoid as a kind of pulley, redirecting force from behind the ear near the mastoid process down and forward to the underside of the chin. The hyoid is not a passive attachment point in this system. It is an active mechanical hinge, a fulcrum through which forceful oppositional tension is threaded and balanced. This is why the position of the hyoid matters so much more than people assume when they first hear about it. It is not simply a landmark. It is a functioning part of the pulley mechanism that determines how tension moves through the floor of the mouth and into the lower face. When the hyoid drifts downward and forward, the position it settles into after years of forward head posture, the geometry of that pulley changes. The angle of pull through the digastric sling changes. The mylohyoid, stretched thin and wide beneath it, loses some of the tautness that once held the floor of the mouth in a higher, firmer position. And the visible consequence, the one people actually notice in the mirror or in photographs, is a softening along the jawline, a fullness beneath the chin that no amount of jaw exercises addresses, because the source of the problem was never muscular weakness. It was postural drift acting on a mechanical system with a very specific, very unforgiving geometry. This is worth repeating because it is the part most people skip past too quickly. This is not a story about weak muscles. The muscles of the floor of the mouth are, in most people, perfectly capable of contracting with full strength. The problem is not strength. The problem is address, where the hyoid sits, and therefore, what angle the muscles are being asked to work at, and therefore, how much of their strength actually translates into lift versus how much is lost to a geometry that no longer favors the face. Think about what this means for the exercises so many people have already tried. The chin lifts, the tongue presses, the neck curls done in front of a mirror, repeated daily in hope of firming the area beneath the jaw. Some of these exercises are not wrong in principle. They do engage the relevant muscles. But if the hyoid itself has drifted into a lower, more forward position because of years of head posture, then exercising the muscles at that compromised angle is like trying to tighten a rope by pulling harder on a pulley that has slipped out of alignment. You can work the muscle as hard as you like. The geometry limits the result. This is the piece of the puzzle that explains why so many people who exercise diligently, who take care of their skin, who do everything the conventional advice tells them to do, still watch the lower third of the face soften year after year. They were never given the missing variable. Nobody told them about the bone that floats, or about the 2-4 system, or about the daily, cumulative influence of head position on a mechanical structure that has no fixed anchor of its own. They were told to work harder on the muscle. Nobody told them to look at the angle. And here is where the conversation becomes practical rather than purely descriptive. Because once you understand the mechanism, the question naturally becomes, what changes the angle? What restores, even partially, a hyoid position that has drifted downward and forward over years of habitual head posture? The answer begins, as these answers usually do, with awareness of the posture itself. Not as a moral failing, not as something to feel guilty about, but simply as a mechanical input that has been running in the background of your life without your notice. Every hour spent looking down at the screen, held below eye level, is an hour spent asking the muscles of the neck and the floor of the mouth to hold the head's weight in a position that gradually reshapes where the hyoid sits at rest. This is not a dramatic, single moment kind of damage. It is closer to sediment. It accumulates so slowly that no single day of it is noticeable, and yet the years compound into a visible shift. Correcting it then is not about a single exercise performed with great intensity for a few minutes a day. It is about restoring, across the hours of an ordinary day, a head position that does not continuously bias the hyoid downward and forward. Raising screens to eye level. Noticing the moments of prolonged forward lean during reading, during phone use, during the countless small tasks that fill an average day. None of this is glamorous. None of this makes for an exciting 5-minute routine, but it addresses the actual mechanism, rather than exercising a muscle at an angle the mechanism has already compromised. There is also a second piece, one that works alongside postural awareness, rather than replacing it. Targeted work on the suprahyoid muscles, the group that includes the digastric, the mylohyoid, and their neighbors, performed specifically with attention to lifting the hyoid toward a higher resting position, rather than simply contracting the muscles in whatever position they currently occupy. This distinction matters more than it might sound like it should. An exercise performed without attention to the starting position of the hyoid reinforces whatever position the hyoid is already in. An exercise performed with deliberate attention to lifting that position, holding it, and returning to it as a new resting default can, slowly, over months rather than days, begin to shift the equilibrium point of the whole 2-4 system. This is not an overnight transformation, and anyone who promises you one is not describing anatomy. They are describing marketing. The hyoid did not drift into its current position in a week, and it will not shift back in a week either. But the mechanism is real, and the mechanism is addressable. And that is a very different situation from the one most people believe they are in, which is that the softening of the lower face is simply an unavoidable feature of aging, disconnected from anything they do or don't do with their own head and neck across an ordinary day. Sit with that distinction for a moment, because it is the actual point of everything that has been said here. Aging is real. Tissue changes over time, regardless of posture, regardless of anyone's diligence. But a meaningful portion of what people attribute purely to aging is, in fact, mechanical. The accumulated result of a floating bone answering, hour after hour, year after year, to forces that were never balanced in the first place. That portion is not fixed. That portion responds to attention, to awareness, to the kind of patient, unglamorous correction that rarely gets discussed because it does not sell as easily as a cream or a device or a single dramatic exercise. You now carry a piece of anatomical knowledge that very few people outside of anatomy departments ever encounter in this kind of detail. Not because it is secret, it sits in every anatomy textbook, described in clinical language, illustrated in cross-section, but because almost nobody translates it into something usable. Almost nobody connects the floating bone in the throat to the way a face looks after a decade of looking down at the phone. That connection is the actual gift of this conversation, more than any single fact about muscle bellies or fibrous slings. Carry it forward. Notice your own head position over the next few days, not with anxiety, just with attention. The same attention you would give to any new piece of information about your own body that turned out to matter more than you expected. And if the opportunity arises, pass the idea on the way these ideas are best passed on. One sentence, spoken to one person, at the right moment. There is a bone in the throat that floats, connected to nothing but the muscles pulling on it. And where it sits is one of the main reasons the lower face looks the way it does. That sentence is enough. The rest, if the listener is the kind of person who keeps thinking about things, will follow on its own. The bone that floats has been there the entire time, quiet, suspended, doing its structural work without asking for recognition. It does not need a name in general conversation. It does not need credit. It only needs, finally, to be seen for what it actually is. Not a curiosity of anatomy, but the quiet architect of a face people spend years trying to understand through every explanation except the right one. Now you have the right one. What you do with it from here is the only part of this story still being written.